the older part, like myself. And then what we will do, we have 2 talks on geriatrics or older patients, and we will have the questions after those 2 talks. And then we have 3 talks on pediatrics, and we will have the discussion after these 3 talks, and we can have maybe after that a panel discussion with everybody, depending a little bit on the time that is left after the talks. And next to me is Amir Jarafi.
Amir Ghaffari.
Ghaffari.
Yep.
My co-chair, I'm Jan-Willem Greven, and we are still waiting for Lillian Kou, but we can start the session because I think she's occupied elsewhere. So let us introduce the first speaker. You'd like to do that?
Sure. I don't have your formal bio, Dr. Arts, but so I invite Ido Arts up to speak. And so, again, maybe you can introduce yourself as far as
I will.
what all your degrees and everything. I looked you up on the internet. There's a lot about you. On the internet, but you don't want me to go.
Good or
through all
bad?
that.
Luckily, it's with the clothes on. Good.
So now the team is complete.
Lillian entered the room as well. Welcome, Lillian. Thank you so much, and a very warm welcome to everybody interested in the young and the old, let's say. And of course, I've been around many of you here in the audience I've already met, which is a good thing. But apparently there's more under the sun than pre- and perimenopausal talks, let's say. So now we're going to talk about, is old age a limit? The indications, benefit, and risks. Short introduction. This is me, and I got my PhD on the subject, bariatric surgery, in part the complications. Actually, Jan-Willem was at my defense, so we know each other quite well as well. These are my conflicts of interest, and I really do like treating patients with overweight and obesity, or suffering from, which is a more polite way to say it. And I do that in a couple of my own clinics, and I have a small hospital. It's good to know who you have in front of you. These were my cases of last year. So this is my clinics together with colleague Fritz Behrens. As you can see, we do not only treat patients with surgery, but also with balloons and GLP-1s. So it's 59% surgical and 41% non-surgical. Now going back to the subject. What is there to know in general? Now, if you look at a patient's life, and I'm male, so sorry for the females, but I chose to go through the life course of a male patient. These are obviously non-overweight or not even obese, but we are as surgeons considering surgery in certain age groups, and it changes luckily. For many years, we focused on this group. So that means the age, let's say 18 to 60, 65 years. And luckily, after the first 2 lectures, we are going to talk about extending that a little bit to the left, let's say. And for this talk, we're going to go a little bit further to the right. Is it a good thing that we're extending? In my opinion, yes. And everything I'm going to talk about is personal opinion. I don't want to force any of my ideas upon anybody. But this is what I see in practice happening all the time. In the mid-range, actually many of the surgeries chosen are either sleeve, Roux-en-Y's, or OHGBs. And, well, in general, they work out fine, right? Now, if we go looking at a younger age, some additions come to place. And especially balloons, poses, or endoluminal treatments are sometimes offered in the younger age. And that all has to do with risks. And that is why many, I do not agree on it, but many surgeons and healthcare professionals consider the bypass types a no-go for the earlier ages. Is that a good thing? Because extending it all the way to the right, so going back to the older age, we see a similar thing sometimes happen. We are a little bit hesitant. And of course, with now GLP-1s into place, there's a new treatment, a new kid on the block. But if you have a patient with obesity class 3 or over, then you can also ask your questions about which type of surgery would be best. Because if we are hesitant as HCPs, and we want to give the benefit of the doubt, don't wait too long, of course, because otherwise, as a clinician, you are too late, and perhaps the patient has already died from other things. Good. Now, of course, this patient is still alive, and we have to look at the benefits that we're introducing to that patient. And we're always talking about extending life and life expectancy, which is great, but in case of a patient of, let's say, 75, getting surgery done, he might live 1 or 2 months longer than expected, but I would not say that the most benefit is in that increase in life expectancy. As is perhaps, that was my opinion at first before I had to make this talk, is there a real benefit for, let's say, type 2 diabetes, all the comorbidities in there? Do these patients react as good to the treatment, let's say bariatric surgery, as you would expect from younger patients? In my opinion, the real benefits are in the simple things in life. The quality of life, let's say. And quality of life is different for everybody. But being very, very heavy means that for Dutchies, you cannot no longer drive your bicycle, which is an important part for some people's life. You can't go out and play a little bit of soccer, let's say, or simple things. We actually have patients coming in that are referred because they need additional help and can't get out of the house, can't get to a old man's home, let's say, because they are too heavy, and because of the legislation, they need 2 nurses to treat them every time, because otherwise the weight is too heavy, and they are rejected and have to lose weight for that sense. So for example, simple things as going to the toilet by yourself might be a great improvement in quality of life if you can't. What we'd rather see at this age is people coming in with a very honest and honorable question, because their own kids got kids themselves. So the quality in life most often is, I want to play that same soccer football over there with the 2 little ones that just got born. And that makes sense, right? Although you might only have 10 years to live, if you have that in a full quality of life, then you would hand that to any patient, right? Age specific. Now, what treatment should we give our patients? Actually, you could look at it the other way around, because why not say, in this patient, is there a reason not to do the surgery? So, in first instance, going in the discussion on, we're gonna treat you anyway. How? Different question, but not turn the patient down in the beginning. Just focus on what you could do for that patient. And it's good that the new, let's say, rules have been out there for now more than a year by the ASMBS and the IFSO, and it has a paragraph on operations in the elderly. 5 to 6%, so patients over the age of 65, are estimated to get surgery nowadays. If you go to the references of the same article, there's a couple of very good ones, I can tell you. If you find some time, it really makes a difference on how I looked up until these patients and the treating. This actually comes from a very large American database, and they looked at, I think, 80,000 people and picked out the patients with an age over 70 or 70 and older, and they compared it with a group of the 49 to 69ers. So we had 2 age groups, one over and one under 70. And they first looked at the elderly, and 86.5% had a sleeve, the rest had a Roux-en-Y, and they matched that with similar age groups with a similar surgeries as well. Now, what came out of there? And this is one of many. So this is, in my opinion, one of the best, but this is one of many, and actually they show always the same. In terms of bleeding, major bleeding, which needed some sort of re-intervention, so that means IV or re-operation. Only in Roux-en-Ys there was a difference, significantly at least. 5% in the elderly to 3% in patients under 70, which is quite a lot, I must say. I can't remember having 3% of bleedings, but apparently in this study it did. It is data, by the way, from 2015 to 2017, so keep in mind a lot has changed since then. Leakage, only significant in patients who got a gastric sleeve. And leakages in the elderly are terrible. They're always terrible, but of course if you have a leak, it's a high pressure system, so that will take you a lot of work to actually fix that again. Significant. Then the comorbidities, and this was quite surprising because they also matched on comorbidities. And actually, the reduction in comorbidities was exactly the same. So we should not be biased, in my opinion, that the elderly might not benefit in terms of comorbidity as much as the younger patient. Last but not least, looking at, unfortunately, excess weight loss, which is not the superior way of measuring, but it's 65% for Roux-en-Y versus 69% in younger patients and 53 to 58. In my opinion, not really a big difference, but it was significant in both types of surgeries. Now in selecting, there's another very nice article, again, very extensive, that is what was used as a base for this remark in the conclusions of the ACE-MBS and IFSO guidelines of 2022. So actually the statement is, there's no upper age limit, no longer, there's none. So any patient with any age should be considered for surgery, but you have to look at a couple of things. It's about comorbidities and frailty. And actually I didn't know what frailty was up until a few years ago. But luckily there are other authors that are better on the subject. So, what is considered here is, in terms of comorbidity, that there's a threefold chance in patients over 70 that they would die within the first 30 days of surgery, which is quite a lot, you might think, but it's still really, really low. Two groups. Patients with more than one comorbidity, especially the combination of type 2 diabetics, sleep apnea, and hypertension came out significantly worse than the ones that did only have 1 or 0 comorbidities. And main problem was Roux-en-Y's. Especially leakages led to death here, which is surprising because a leak after a sleeve is quite often much more severe than a leak after a Roux-en-Y. So if you considered the comorbidities, then you go for the frailty index. And frailty is just having the patient over, getting to sit across you, but you also should have looked when he was walking down the hallway. 44% of the 60 plus elderly, at least in the US, appear to be considered frail. That means a higher vulnerability during surgery. How can you score it? They have a low grip strength, they report low energy levels, and actually they walk relatively slow. Low visual activity, and the last one is a little bit difficult because the last one is unintentional weight loss. Well, that's hard because these patients come in for weight loss surgery. What frailty also showed was it got higher with a higher age and a higher BMI, but just. In total, my conclusions for these elderly patients that really need help is that there's no longer an age limit. You should consider all. But do consider comorbidity and frailty in every patient, because the one 75-year-old is not the other. If you look at my father, I hope I will be as, well, physically active, etc., as he is at his age, 73 now. But I can tell you that many of his friends have already passed away because of things like frailty. And thus far, I'm going to say thus far because, for example, an ORGB has not been considered in research. The sleeve gives less morbidity and less mortality. So thank you so much for having me, and we're going to go to the next.
Thank you very much. As we discussed before we started the meeting, we will have the 2 talks on the elderly patients, and then the questions, and then afterwards we have 3 talks on pediatric treatment. So the next speaker is Cilla Haywood, and unfortunately no bio, so please tell us who you are.
Well, Celia is a geriatrician from Austin, so she's well qualified to speak on this topic. So thank you, Celia.
Thank you. My name's Cilla Haywood. I'm a geriatrician by trade. I did my PhD with Joe Proietto, who apparently everyone knows. I have no conflicts of interest to declare because nobody cares about me because I'm a geriatrician. Nobody gives me anything. Not even a €50 dinner. Not even worth that. So you might have, when I'm a very determined person, and I said that I wanted to do some study on obesity in older people. One of the professors of geriatrics said, "Oh no, obesity is good for older people," and it's like, you want to bet? And every time I see him at a conference now, I tell him about what I found out in my PhD, and he say, "You tell me that all the time now." So it's like, well, don't tell me I can't do something. We'll talk about the obesity paradox. We'll talk about lean mass loss, which is a bit of a bone of contention. What's the evidence for medical treatments? I'm a physician, and we do have older people come up in our bariatric surgery meetings, and we discuss them. And I'll discuss my approach to treatment as a geriatrician. So this is this paper. This is from a paper nearly 20 years ago now that showed obesity was a problem of increasing frequency, and the highest rates of obesity are actually in the boomers, the baby boomers, and obesity might not be associated so much with mortality, but it is associated with disability, and that's actually, when we talk in terms of health budgets, that's actually more of a problem. So the effects of obesity in older people, and I also apologise, I can't do the pictures like the previous speaker, so I'll have to focus on words, but I'll try and learn that stuff for next time. In older people, they have increasing fat mass, decreased muscle mass and quality, and decreased total energy expenditure, worsening of their cardiovascular risk factors, worsening of osteoarthritis. And really interestingly, and this is what I found really interesting when I was doing my study, the inflammatory milieu in obesity is the same as in the frailty syndromes and degenerative syndromes of ageing, Alzheimer's disease, for example. And Alzheimer's disease has been informally referred to as type 3 diabetes, and there's some study, it's a really interesting area, and there's some studies coming out about incretin therapy, effective incretin therapies on Alzheimer's disease and potentially for prevention. So watch this space. So frailty, so that's my cup of tea. That's what I do every day as a geriatrician. And it's about basically a geriatric syndrome of reduced reserve and increased risk of adverse outcomes. And unintentional loss of weight or loss of lean mass is one part, but you need 3 out of 5 of the symptoms that you spoke about to get to be diagnosed with frailty. Or we use the clinical frailty scale or the frailty index. Symptomatically, weakness, slowness, exhaustion, and people with abdominal obesity and insulin resistance have a higher risk of frailty. So one potentiates the other. There's also an increased risk of falls and fractures. So people think about osteoporosis, but they don't think about falls risk. So that needs to be considered as well. And if you don't fall, you're not going to fracture, really. So who thinks about the obesity paradox? Who thinks the obesity paradox is still a thing? You want to put your hands up, or are you too shy? Nah, we don't. Okay, we're cool here. The problems with it was that weight loss often precedes death, that smokers have lower body weight, that heart failure is diagnosed earlier in people with obesity, so they're diagnosed and treated earlier and they're less likely to die earlier. Collider bias as well, so lots of interacting diseases will impact and cause a different effect to what we expect. Also, I don't really care if somebody who's 80 has a BMI of 35 and they're otherwise well, I'll say go and enjoy your life, have a piece of cake. If their BMI is 50 and they can barely walk, that's a different matter. Increased waist circumference is also an independent association with increased mortality and frailty as well. The other thing is Edo alluded to that mortality is not the only income of interest. We're interested in keeping people well and not disabled for longer. And the obesity paradox doesn't mean that intentional weight loss will kill people. At least I don't think so. So lean mass loss. This is a bit of everyone gets a little bit, and the jury's still out on this, but this is my take and my understanding in the literature. So ageing is associated with decrease in muscle, bone mass and quality, and increase in fat mass. So people with obesity have a higher absolute lean mass. However, physical function is worse in older people with obesity than in non-obese persons. So absolute muscle mass and physical function and not well correlated. So I sort of think about, whenever I think about muscle mass and strength, I always notice that furniture removalists are really skinny, but they're jolly strong, I tell you what. So I always think about that. When we lose weight intentionally, roughly 75% of that is fat and 25% of that is lean mass. So absolute lean mass decreases, but relatively the percentage lean mass goes up. And that's when they've done the studies and the correlations, the physical function changes have been correlated with fat mass. So the more fat mass you have, the less able you are to physically function. And there's also, when you lose weight, there's potentially improvement in muscle quality. So the intramuscular fat, the intramuscular inflammation goes down. That's the theory. And there's been some studies with muscle biopsies and stuff. And also they've done some studies looking at 1 rep max after weight loss, and it's the same. So if you've done weight training. So weight loss achieved by calorie restriction with multimodal exercise, I'll talk about that a bit more in a moment, improves physical function in older people. And so we're talking about the order of 10% weight loss. So, you know, what about drugs like semaglutide, tirzepatide? We don't know what the effects are going to be. Potentially tirzepatide's a little bit better, but we don't know at the moment, so I can't answer that. What about bone mass? And this is a story about how I got interested in obesity as a geriatrician in the first place. And obesity doesn't confer the expected protection against osteoporotic fractures in older people. So my first year of training, I saw an older person with obesity in bed with a fractured NOF, and I thought, well, that's not right. I didn't think that people with obesity got NOFs. And the narrator said they do get NOFs. So people with obesity have higher bone mineral density, however, fracture risk per BMD category increases. So BMD is not the sum total of fracture risk. And people with insulin resistance have poorer bones, and also falls risk as well. So people with obesity have poorer balance and they fall over more and sustain fractures in their wrists and ankles. And if you're obese and have a fractured ankle, that buys you an 8-week hospital visit because you ain't moving and you're less able to use a frame. So we have them looked after for a long time. And again, there's an unclear interaction between incretin therapies and bone mass. So what do? We ensure optimal protein intake, and from what I can find, it's 1.2 to 1.5 grams per kilogram per day of weight adjusted to a BMI of 27 was what I could find, or somewhere between ideal and actual body weight. Ensure adequate calcium and vitamin D. So I studied in my PhD, I looked at an RCT with VLCDs in older people and actually found the VLCD group, the vitamin D went up, and I think that's due to vitamin D being sequestered in the fat, and when there's fat burning, the serum vitamin D goes up. Progressive resistance training can offset lean mass and make you stronger, so that's really good. And also balance training. In practice, that's a class. So I tell my patients 3 classes a week. And there are exercise classes designed for older adults. And there's a social element of that as well that's really important. So get a dietitian to see them and do multimodality exercise, and VLCDs are good. So my approach to treatment in the older person, comprehensive geriatric assessment, there's often multiple issues, there's competing risks and benefits, and we deal with a lot of complexity in geriatric medicine. So which is the issue of most concern? What would you most likely to help? And what are the goals and why? So 10%, so I aim for about 10% weight loss, more or less achieved with calorie restriction, usually a VLCD, because total energy expenditure is less. So in order to get a deep calorie deficit with good nutrition, that's what I find the simplest. And I find older people very grateful for not losing modest amount of weight, because the medication, particularly blood pressure, goes down. I found it very useful. I've seen a lot of people on 3 different agents for blood pressure, and they can come off 1 or 2 of them. So they're grateful. Their knees are better, their hips are better. And in fact, I see a lot of I do pre-op assessment in older people, and I see a few people that are obese and being considered for orthopaedic surgery, and I send a few of them off I suggest to their local doctor that they start on VLCDs and semaglutide or tirzepatide. There's no specific trial looking at incretin therapies on older people, but it's likely that we're seeing, you know, all the cardiovascular outcome trials and everything that's good for everything ought to be in the water. I didn't say that, but they're really good. I'm collecting a few patients sort of, you know, around 65 that have had bariatric surgery and haven't had great weight losses, and I think that's to do with the fact that their total energy expenditure is low. So I put them on a VLCD and tirzepatide, and I find that sort of, you know, first thing I modify their expectations around their weight loss and sort of shift their goals to more, you know, often they've got a lot of internalized, you know, we all grew up in diet culture with internalized fat phobia. I say, no, it's more about keeping you out of a nursing home nowadays. Let's look at what we can do to keep you out of a nursing home. There's no clear upper age, as well as Edo said. I recently saw an 86-year-old with debilitating hip pain, and I was sure she had obstructive sleep apnea, had very uncontrolled hypertension, and I said, look, go away, do this. Let's try and get 10% weight loss off you. Multi-modality exercise is non-negotiable. If they can walk, they should, or even if they can't walk and they can start in a chair, they should try and get up to walk. VLCD I find, and the dietitians might fight with me here, that's okay. VLCD is nutritionally adequate, and I did that and published that, and can add protein supplement like a whey protein isolate, and also watch their blood pressure and glucose as well. If they're on any glucose lowering agents, they're on the side of maybe taking them off their sulfonylurea, halving their insulin, depending on what they're starting blood glucose and HbA1c is. And, you know, it's important to bear in mind that older people are especially vulnerable to getting the ill effects of hypoglycemia, postural hypotension. Thank you very much for having me. I've got some further reading, and you can hit me up on my email if you've got any questions or want me to come over to Bali to your conference and speak. I'd be very happy. And then I can put something on my conflict of interest.
Thank you. Please stay. Can we have the mic? Yeah. Well, the two papers are open for discussion. Are there any questions from the floor? Maybe I can start with one question, because we talk about elderly patients, but are we talking about calendar age or biological age? Because you do have patients that we all wouldn't consider for any treatment looking at the biological age.
Of course, we're talking in publications quite often about the calendar age, but there's 50-year-olds that you rather not do surgery on because of their biological age, let's say. They've been smoking all the time, etc. So I'd rather look at biological age, but for clinical research, it's easier to do it like this. But about the remarks about comorbidities and frailty, of course, you're quite obviously looking at the biological age, actually.
I look at them and think, do I have any reason to think this person won't live another 2, 3, 4, 5 years? So anyone with a prognosis of more than 3 to 5 years, I saw an 86-year-old who's probably going to be dead within a few years, but there was sort of benefits, I could foresee benefits within the next year to treating her medically. She probably wasn't going to score bariatric surgery, at least not in the public system, but definitely treating her. And there were things that we could treat that I knew would be effective for her, so why not withhold it if I think it's going to be effective? And
hello, Louise Bauer here. While I'm a paediatrician, I'm interested in the whole age group, and perhaps I'm asking the question here as past president of the World Obesity Federation. So I just, first of all, relevant to what you've just said, tomorrow morning's plenary on the Lancet Commission on diagnostic criteria for clinical obesity is actually relevant to this because it gets away from potentially, it's about thinking about health rather than specific cut points around things. So I just want to mention that. I was wondering if you could just reflect further on how you might assess biological age, how you might think about what sort of things we clinicians could take into account rather than having hard age cut points. Could you give us a little bit more idea about the sorts of things that, say, a GP, other such clinicians might take into account in thinking about what might be available, and particularly in terms of maybe pharmacotherapy options or VLEDs or similar?
So that's a really good question, and I don't really think about chronological age. Doesn't come up in my mind, but I sort of think how vulnerable is this person. So if I were to subject them to anything, would they, so I do pre-op assessment for surgery, and this is something I think about often, and I sort of think about the person versus the insult that we're going to put on them. And also their chronological age. When would I expect them to die just based on statistics? So say, an 85-year-old has already, the average life expectancy for a man is about 82, and women is about 86. I add on that, their medical conditions, what's the activity, how many hospital admissions they've had, what their functional trajectory has been as well. So function, in every different disease, their function is a really important prognostic indicator. So have they gone down, I just ask them, has your relative gone downhill in the last 6 months? And if they say yes straight away, that means that I think they're going to die soon. So I look at, it's very individual, and I don't sort of think of chronological age. I think about the person versus the insult that we're going to put them through. So an 86-year-old who's, got multiple medical problems that are unstable, going in and out of hospital, and their function's declining quickly, they're probably losing weight as well. I've never seen somebody who's very obese who's in that. But I see a lot of patients who are sort of 80, they've got a few medical problems that are stable, and their function's mainly limited by the fact that they've got a buggered knee. I'd start them so I look at the patient and what I can fix, and that's what, as geriatricians, we don't like, or maybe I'm as geriatrician, meaning me, I don't like sort of chronological age and reducing people to a scale. And geriatric assessment's very multi-dimensional as well. So I think, what am I trying to fix? And what's the risk benefit, and and generally speaking, obesity medications, compared with what we can actually do to people, they're very, very safe. So you can start somebody, they don't tolerate it, you take them off, no problem.
Considering surgery, there's something else, because you can have all the scores you want, but it's also a little bit of a feeling. I can't really explain what, but if you see a lot of patients, on average you will see the patient that you're like, this one is probably gonna make it, whilst the other one, although really wanted to go for surgery, you're like, nah, and then most often there's reasons not to also. And never make the decision by your own. So I would ask a colleague who knows way more about this subject than I would, and come together as a whole team to finally make a decision on what type of treatment we should give it. So we let go of the age limits, right, in the guidelines I showed you, but still that doesn't mean that just one people is gonna make the final decision, in my opinion.
I've sat in on some of the bariatric meetings, and so if it's an older woman particularly, and they want to considering surgery, I'll say try them on a VLCD, and because I've seen older people just not get the weight loss, so I'd try them on a VLCD and medicine first, and that's a better stress test for them to see what they can lose. Yeah, and you might consider it then.
It depends for me a little bit on the amount of excessive weight. So if they are humongous,
last question, and then we continue with the younger, and at the end, when we have some time left, you can come back.
Celia, do you have a preference for a particular type of bariatric procedure? And do you advise your patients, or do you allow the surgeon to make the decision?
Most of yeah, look, that's a question that's it's a good question, but it's one that we've had such constrained access to bariatric surgery with COVID, just that we're just not getting that many patients through to bariatric surgery. So most of the time it doesn't cross my mind surgery. I'll try them on some drugs first. But yeah, I agree, just listening to the surgical talk, the less sort of messing around with, to use a technical term, with an older person, the better, as far as I'm concerned. So a sleeve more than a Roux-en-Y, and that's borne out in the evidence there.
The only thing you can't do with a sleeve is reverse it. Keep that in mind if you're in doubt. An OEGB, for example, you can. Sorry?
There may not be sufficient time for
That is true. But it might.
Okay, I think we will continue now with the second part of this session.
Thank you.
Thank you very much.
So we'll move on to the other extreme age group, and it's my pleasure to invite our first speaker, Dr. Sanjeev Khurana, who is a pediatric surgeon from Adelaide. He's been very passionate about surgery in the adolescent group, and I think he's going to talk to us about why we shouldn't be too afraid to operate on kids.
Thank you, Madam Chair, and the organizing committee for this opportunity. My day job is that of a pediatric surgeon. I have dibbled and dabbled and maintained an active interest in pediatric obesity surgery after having listened to Paul O'Brien in the early 2000s. And I work in this space with Lillian and Jacob. And my remit was, are we too afraid and what's the data? So I have a direct conflict of interest which I would like to declare when it comes to data. And if I had to answer this in one word, are we too afraid? The answer, of course, would be yes, because data transcribed into our current guidelines, which are globally accepted, would suggest that children and adolescents with severe obesity are candidates for surgery. You would think that the data is clear, to the extent that now, as per the ASMBS IFSO guidelines, there really shouldn't be any constraints on the Tanner stage, and that bone age should not really be a consideration for requirement. And increasingly, the barriers are being broken in terms of syndromic obesity, developmental delay, etc. So this is what the crystallization of current evidence has occurred in terms of our guidelines. And I would stress, while these are surgical guidelines, some of them are reluctantly supported by our physician colleagues. And I have seen that journey evolve over the last 15 years. So what is this data? And the real question is, it's not do we have data, is it how good is this data? And more to the point, is this even a question that we really need to even address ourselves today, given the age of Ozempic? So let's just quickly go through the efficacy data. And when it comes to adolescent bariatric surgery, there really are three procedures that we can talk about in terms of long-term evidence. And I'll start with the lap band because it's no longer really in fashion, which is a separate conversation altogether. And it's also because really the home of the lap band was Australia, and for various reasons it's out of the picture, and so it's not really worth talking. So we are left really with two procedures, the Roux-en-Y gastric bypass and the sleeve gastrectomy. The Roux-en-Y, of course, is the oldest and is still considered the benchmark, and now in the world of adolescent bariatric surgery, over the last decade or so, we do have some quite robust data from various parts of the world which talk about what the long-term outcomes are. And interestingly, when it comes to the sleeve gastrectomy, which is by far the preeminent procedure of the day, the real data that has been the basis of our guidelines has come from the Middle East, and through the good work of one pediatric, duly trained pediatric and bariatric surgeon, and I'll talk about these in a second. So, in summary, if I had to look at these weight outcomes, etc., there is a really good mini review which has been done by our physician colleagues recently. Looking at these precise studies, these studies come from Sweden, they come from the North American studies. There are two centers in North America. One, of course, is the Teen Lab study, which is a collaborative, but then there is this really interesting paper from Miami, and of course Al-Qahtani's group from Saudi Arabia. There is no question that the weight loss outcomes can absolutely mirror what we see in the adult world, and that's not a problem. But when you look at the cardiovascular risk factors, there too there's little controversy that we can do good. No question about that either. The complication profile of all these procedures is also now quite well documented and is not controversial. We know that they're going to get nutritional deficiencies. We know that they're going to need further procedures. Doesn't matter which operation you do. This idea that you do one operation, which is the gastric bypass, so that you don't have to do more, is bunkum. We know that there's going to be about a 40% reoperation rate whichever procedure you do. And the presence of gastroesophageal reflux with the long-term concern of Barrett's esophagus is an active problem with sleeve gastrectomy, especially in the young. And of course, the esophageal motility disorders, probably not so much, given that we are not doing the band anymore. But what about the other soft factors? What about the things that are really more in the realm of this young growing adolescent who is morbidly obese and who is going to lose their growth potential, growth as an individual, because of their mental health problems, their ability to actually become an active, productive member of society? And so this really elegant piece of work, which is a byproduct of the Swedish adolescent morbid obesity study data from their Roux-en-Y gastric bypasses, which were in a non-randomized manner control matched with their Swedish childhood obesity treatment registry. And they did some data linkage, and they looked at the use of psychiatric drugs and treatment with mental health specialists. And what they found was, actually, there was no difference. In fact, the ones who had obesity surgery had more interaction with psychiatric specialties. And at the end of 5 years, there was no significant improvement, in their words, bariatric surgery versus mental health problems. I would like to qualify that, because the only operation that the Swedes know and do really, I hope there are none here, is the Roux-en-Y gastric bypass. So that is some seriously strong data. So they also, in their surgical group, had done these self-reported questionnaires, but they did find that there was definitely an improvement in their eating disorder side of things, emotional control, but that, more importantly, a relative change in BMI was not associated with the presence or absence of binge eating disorders as baseline. Which is why we see now the idea that if you have an adolescent who has got mental health issues, depression, eating disorder, the boundaries are starting to be pushed in terms of intervention for them for a weight loss measure. But that's the kind of data we are basing it on. I move on to the next study, which comes from Miami, and this, in my view, is a seminal piece of work. It is the longest follow-up that we have got at the moment from bariatric surgery in adolescents. So this is a single surgeon's experience over 2002 to 2010. 130 patients who were identified whose age at surgery was less than 21. They did go into their teens as well. The minimum period past their surgical point was 10 years. They had all been, in quotes, lost to follow-up. And this data was collected as real-world data because they were not as part of any research study. Interestingly, given the time span over which the study was done, the vast majority, again, were Roux-en-Y gastric bypass, but they were a smattering of bands and one sleeve gastrectomy. And of note, not that we're going to talk too much, but this is my last aside about bands, they found that actually some of the bands were still in place and didn't really cause a problem in their view. So what were the outcomes? Again, they had good weight loss. I'm not going to waste your time on that. The first slide was really about that there was no difference in the ones who were not studied versus the ones who were studied, and there was significant weight loss. But when you look at the other outcomes, 67% had now got anemia. There was certainly improvement in their back pain, depression, diabetes, and the main problem they found actually was anemia and reflux in the long term. However, they also reported that 84% were currently employed, 60% nearly were pursuing or had already done a college degree, and 67% of females had had a successful pregnancy. So when I look at a morbidly obese or a severely obese adolescent today, and I look at their growth trajectory to be able to get to school, and most of them are not even at school. So they have surmised that by doing that intervention, some of these patients were directly affected and therefore achieved something that they otherwise would not have. The most interesting thing was that their regression analysis showed that the only predictor of success was ethnicity. I now move on to the study that, to be honest, is probably the one that we really need to look at. This includes 2,500 children. This is a true pediatric study because it goes down to the age of 5 years. And this is in the hands of one center. They certainly were severely obese, so they're not operating on someone who's got, just over the limit kind of guidelines. What I want to highlight, and yes, they showed weight loss, that's fine. But what they also have claimed to have shown is that actually there is no change in their growth trajectory in the pre-adolescence. But this I find problematic and difficult to understand. That in 2,500 odd patients, there was about a 1% true complication rate where they were readmitted. They talk about staple line leaks, and in our limited series, we've already seen a couple of metabolic neuropathies, and they showed no problems with gastroesophageal reflux. This is a phenomenal piece of work. And it is actually this study that I believe that has led the ASMBS and IFSO to say that you can go and operate now, that bone age is not a problem. I find that a problem. To say that our entire global guidelines are based on this one study coming from one center, because we have not understood the cultural variations, how this works. I should point out that the study from Miami, the other important thing there was that the vast majority of those kids who did really, really well 20 years on, they were majority self-referred. The majority of those patients, their parents were successful, had undergone bariatric surgery. So I suspect that itself actually was the biggest predictor in that cohort. So what about our backyard? Now, as of current statistics, 8.3% of adolescents children between the age of 5 and 17 in Australia are obese. And thanks to one Louise Bauer and her group from New South Wales, this work was done published I think in 2016, where basically what they did was they looked at 4 public health studies done over the time span between 1985, 1995, 07 and 012. These public health studies had measured height and weight of children. So this group basically collated that data, translated that into what would be considered as their class of obesity, and they demonstrated that there was a significant rise in the incidence of severe obesity in children, such that by 2012, 2% of this group were already class 2 obese and 0.5 were class 3. So if you extrapolate that to today's ABS data, which shows that we have 1.6 million children in that age group, we have 30,000 children in Australia who are class 2, and we have 8,000 who are class 3. That to me is the minimum burden of disease that in the age of Ozempic, we better be thinking how we're going to treat. So where's the Australian data on our interventions? We now, of course, have a very mature bariatric surgery registry, and it is now collecting some serious amount of data. However, when it comes to children, the way the registry is currently reporting its data, first of all, their lower cutoff is less than 20. And in this most recent report, they have reported that there were 8 children less than 18 at the time of surgery. I went back and looked at the registry data, And in 2022, the report showed 18, and in 2020 to 2021, 275. But I could not make out from the previous reports prior to that how many actually had that done. Although even in those reports, they recorded children as young as 13 and a half years having an operation. Further, for all the long-term outcome measures that the bariatric surgery registry is reporting, it is specifically excluding participants less than 18 years of age. So I'm afraid there is no Australian data on how our kids are doing with whatever surgery we've done. I think we need to do better. Having said that, I think at a global level, I think there is now reliable data on the effectivity of bariatric surgery in this age group. We have a predictable profile of their adverse effects. It's certainly better than no intervention in many instances. We don't have a reliable model of predicting who's actually going to do better. But I question the push to rolling this out to prepubertal adolescents till there is more robust data from other centers. So where to next? Of course, we are in the age of Wegovy. This is the TGA information guide for Wegovy as it pertains to children and adolescents. Anyone with a prescriber number today can prescribe Wegovy. And we've heard that the annual cost of Wegovy is going to be $5,000 on a prescription. You multiply that by 40,000, and that's the average cost to the nation for treating the potential candidates. And what's this based on? So I believe now the shoe is going to go on to the next other foot. So far, surgeons have been accused by our physician colleagues of finding an innovation, applying it, and then getting the evidence later to understand whether that was the right thing to do. And I worry that Wegovy is going to be now potentially given to anyone and everyone above the age of 12 on a study that basically was followed up for 68 weeks, not months. So does that mean we shouldn't use it? No. I just think we need to be better at accumulating real-world data as we go along. And so the future really lies in integrating into a comprehensive pediatric or an adolescent obesity registry, not a surgery registry, but an obesity registry. And for that, now the surgeons are going to have to actually kowtow to the physicians. Thank you.
Thank you, Sanjeev. Oh,
Yep. Okay. Thanks. So next we'll have Dr. Shirley Alexander come up. So she's a pediatrician in Sydney and the head of the weight management services at the Children's Hospital of Westmead.
Yep, thank you very much for inviting me to speak, and I feel very honoured to be up here following Sanjeev and in between Louise, who's going to finish off the paediatric session. So I have to... I'm a bit like Celia, that I don't have many conflicts of interest. I did a speaker fee in 2021, so I think my conflicts of interest are one step above yours. But I was asked to talk about what would be the future between in treatment of pediatric obesity between using drugs or bariatric surgery. And I will focus a little bit more on the drug side of things because Sanjeev has covered the bariatric surgery. But just to set the scene, pediatric obesity is mainly a polygenic condition. It's a genetic predisposition that's interacting with the obesogenic environment, and it's the adolescents that are living with obesity tend to then go on to live with obesity as an adult, and so this condition is really a chronic refractory condition that we need to be thinking a little bit differently in the sort of chronic model of care treatment mode. In pediatrics, our aim is not just weight loss, it's basically optimizing the health of this young person. And as Sanjeev has said, for example, in surgery, we want to make sure that we're not going to be impacting the growth trajectory of the young person with whatever. So it's the old adage, first do no harm. And what we tend to do is work towards lifestyle behavioral changes that are family-centered and age-appropriate. And we have an algorithm that escalates from moderate to mild interventions to more intensive interventions. And in last year, in 2023, the American Association of Pediatrics published their clinical guidelines on the assessment and management of pediatric obesity. It's a 100-page document, so if you've got some free time, it makes for some good reading. But in that, it includes the algorithm of how we approach treatment in managing pediatric weight loss. And it's dependent on the age of the child and the severity of the obesity. And as you can see there, as the child gets older and has more severe obesity, the algorithm increases from not just modifications of lifestyle and behaviours around eating, activity, sedentary behaviour and sleep, which is almost the sort of forgotten arm, but becoming more prevalent these days. And then we would escalate up to thinking about pharmacotherapy, and then again, if that's not working, which we've until recently we haven't had too much pharmacotherapy to work with, you would then go on to bariatric surgery. So I'm not really going to cover much in terms of the bariatric surgery side of things. I'm sort of going to start in reverse and talk about the surgery and then go on to the drugs, because Sanjeev has covered it all and he's presented far more updated publications. I'm just going back on the diehards of the teen longitudinal bariatric surgery outcomes. But just to highlight that bariatric surgery done in the adolescent population and until more recently, it's really only been the post-pubertal adolescents, ones that we feel have reached their adult height, not going to be affected by having surgery. The data, this data is from America. They didn't tend to do the lap band, as Sanjeev said. That tended to be more of an Australian prerogative or an Australian thing to do. But if you look at the data there, they get a lot of weight loss. There is a little bit of weight gain over the years. But one of the things that Sanjeev has highlighted is nutritional deficiencies, particularly around iron deficiency, increases as the years go by, up to about more than 50% of children have nutritional iron deficiency. And the older they get, the less adherence there is to taking supplements. There's also the concern about the need for repeated or further intra-abdominal procedures that can complicate matters, although it is relatively safe. There is, so Sanjeev presented data that's longer than this. This is only the 5-year outcome data. He was presenting data that's more than 10 years old. But again, the same thing, iron deficiency or nutritional deficiencies, particularly in the Roux-en-Y, less so in the sleeve operations, are very prevalent in the adolescent population. But the 5-year all-cause mortality is very similar in adolescents to adults, and deaths are very small. So if we look at the goals in weight management, bariatric surgery certainly ticks weight loss. They can get up to 25 to 30% weight loss. They also have been shown to improve overall health parameters, but there are some potential downsides. As I said, the complications of nutritional deficiencies, reoperations. We really don't know, though, what a 13-year-old, or even if we do bariatric surgery now in younger people, what are they going to be like when they're 50? What are the complications going to be then? We don't have that long-term data. And also, I don't know where many of you are from, but certainly in Australia, cost is prohibitive for many of our patients anyway, because bariatric surgery is not readily available in the public sector. And so they have to get it privately, and privately it can cost anywhere between $10,000 to $30,000 depending on where they go and what they need. Not sure where it's like in your country, but certainly many of the children, particularly the children and young and youth that would really potentially benefit from this with severe obesity, they often tend to come from families that are lower socioeconomic and can't afford that. So what about anti-obesity medications? Well, this is a really exciting space. There haven't been many for anti-obesity medications for use in adults until more recently, and certainly even less in the pediatric sphere. But it's really exciting space at the moment where we've got more drugs and pharmacotherapeutics that are available to us. However, as a pediatrician, we're often used to using drugs off-label because there often aren't the studies done in the population that we are dealing with. So it is very heartening to see that more and more of the anti-obesity medications are now being approved by the various drug agencies that they're required for approval. So there have been a number of, or a few medications that have been around for a while. Orlistat, a gastric and pancreatic lipase inhibitor, has been around for a while, and it does produce some weight loss. However, we very, very rarely prescribe it, if ever. In fact, I don't think I've ever prescribed it because we found that basically adolescents don't like taking it. The side effects are prohibitive from their perspective, and so we tend not to use it. What we do use, though, is metformin, particularly in patients that have insulin resistance. And we've used it in children down to the age of 6 or 7 because we've actually found that we've had patients that have developed type 2 diabetes in 7-year-olds. So that one has been around for a long time. You know, we build it up slowly because of the side effects of mainly gastrointestinal discomfort and nausea. But if you build that up slowly, it tends to not be so much of a problem. I've put phentermine and topiramate in the sort of old versus new one, although it's a mix of an old kid on the block with a new kid on the block. Phentermine's been around for a while, but again, it's off-label use, or it was off-label use in adolescents for short term, up to a maximum of about 6 months. And if you didn't lose weight after 12 weeks of more than 5%, you should really stop it. But with the addition of topiramate, which was, originally its use was as an anti-epileptic and was found to affect appetite. So they've now combined phentermine with extended release topiramate, and that's actually been found, publication a couple of years ago, found that it was actually very effective, up to about 15% weight loss in adolescents. However, one of the side effects, or one of the concerns around prescribing phentermine and topiramate, particularly in the top dose level, was the need to monitor for suicidal ideation. So now we definitely come to the new kids on the block, and I heard the other day there that they're sometimes labelled nutrient-stimulated hormone-based medications, which I quite like the name of, but a lot of, again, most of the data out so far is in adults, not so much in adolescents. And these medications mimic enteropancreatic hormones, I won't go into too much because I think a lot of that was covered really in the plenary session this morning, but they have multiple modes of action that include on the gut to slow gastric emptying and on the brain to reduce appetite and increase satiety. In adolescents, the current indications are for those that are older than 12, so again means that in our younger age group, under 12, and we have many now who are under 12 and have BMIs in the 40s, 50s, not quite in the 60s yet, but we just don't have any medication that we can really legitimately use other than considering off-label. So adolescents greater than 12 with a body weight of 60, and that would basically be every single patient in our weight management clinic, in the adolescent clinic. As you know, most of them are once weekly subcut injections, and not only have they been shown to improve the outcomes are significant weight loss, they also improve a number of other health indicators such as cardiovascular risks in particular. So what's the evidence? So most of the evidence is in adults, but there are some again, side effects similar to metformin and again been mentioned this morning, mainly nausea, diarrhea. There is data to suggest there might be an increased risk for thyroid tumours, but that just seems to be in rats. And again, you mitigate the side effects by slowly increasing. But we always got to remember that lifestyle interventions are to be included. They are the mainstay of treatment, and your medications or your bariatric surgery, whatever, they're the adjuncts that you add on to lifestyle interventions. So the evidence in adolescents, really, because all these studies are really in 12-year-old and above, are limited, but there are some seminal papers. Liraglutide was one of the first ones published in 2020 and basically showed, again, this was a 56-week treatment with a 26-week follow-up, and all of the candidates received lifestyle therapy intervention, and the results basically showed that liraglutide was markedly superior to placebo, and there wasn't a great difference in adverse effects. However, there were some adverse, there was about 10% where they had to discontinue because of adverse effects in the study. And then the next paper that was published was in 2022, was the semaglutide and the STEP-Teens trial. So that's semaglutide treatment effect in people with obesity in teenagers. And again, it was the drug versus placebo with also all participants receiving lifestyle therapy. As Sanjeev said, it was a 68-week trial, and it was up to a maximum of 2.4 milligrams or whatever they tolerated. But again, the outcomes were very much in favor of semaglutide, even more so than liraglutide. And potentially, if you think about it from an adolescent perspective, doing a once weekly injection is probably much favored compared to a once daily injection. So significant weight loss, little difference in the GI or the gut adverse effects, but there was 4% in the trial arm that did develop cholelithiasis, but none in the placebo arm. Serious adverse events was very similar in both arms, and again, the improvements in the cardiometabolic risk factors was greater in the drug group. And then just this year, there's been a...
to move a little bit faster, yep, because otherwise we won't have no discussion.
Okay, yep, sorry. There was a meta-analysis this year that showed that basically semaglutide is most effective out of all the off-label and on-label drug prescriptions. So anti-obesity medications, again, they do produce weight loss. They do provide an improvement in overall health parameters. There are some complications. There is no data about long-term side effects more than 5 years out from the adult data. And again, there's a cost and equity access, and as Sanjeev has said, it's about $5,000 cost. So comparing weight loss in the anti-obesity medications and surgery, obviously surgery still produces a much greater weight loss outcome than the drugs. However, I think what we need to be looking at is how we go into the future, given that chronic obesity is a chronic relapsing refractory condition. We need to look at whether or not we do combination therapy, whether we do drug holidays, because if you look at the adult data, once you stop semaglutide or tirzepatide, the weight goes up hugely again, but maybe we need to have a maintenance dose, combination of doses, or pre or post surgery pharmacotherapy combination. So in summary, basically, when we're looking at weight management in pediatrics, adolescents and adults, it's not just improved weight loss, it's improvement in health. We have an escalation pathway that we look at adjuncts along the way. We have now some new effective obesity medications, which is really exciting. Bariatric surgery currently is the most effective for weight loss. However, I think we need to sort of watch this space, because I think combinations and new drugs coming, new combinations could produce even better results. So thank you very much.
Thank you, Dr. Lysander. It is my pleasure to invite the next speaker, Professor Louise Barr, who is a pediatrician from the University of Sydney. She's an internationally recognized child and adolescent obesity expert and the past president of World Obesity Federation.
Thank you very much. I want to show my disclosures. I'm going to talk about just a few issues. Some of them are very specifically relevant for pediatrics, but most of them are broader. And I want to come up with the problem is that most health systems fail to address the needs of people of any age living with obesity in multiple ways. A few years ago, in the World Obesity Federation, we undertook this study where we assessed the readiness of national health services to provide weight management and obesity treatment. We had surveys and semi-structured interviews with over 270 respondents from 68 countries. We also did a rapid literature review. Now, I'm just going to give you a bit of a headline finding of some of the findings here. Well, guess what? Not surprised. In most countries, there is a lack of recognition of obesity as a disease. And countries have varying approaches to funding treatment, with out-of-pocket payments being the main funding source in almost a half of those countries, and only 4 countries at that time had government funding insurance coverage as the main funding source. And there are long waiting lists. And there are different care pathways, with primary care being the most common entry point into the system in most countries, especially when people have comorbidities, not before they have them, but when they have them. And those in rural areas have difficulty really entering the healthcare system. We can really appreciate this in Australia. And many people struggle to stay in the system. There's a lack of initial referral, followed by lack of treatment options or care pathways, especially in lower middle and low income countries. But it's a challenge even in high income countries such as Australia. Further, there are low levels of health professional training in obesity care, so the availability of training is lowest in lower middle and low income countries, and dietitians or nutritionists were considered to be the most trained to deal with obesity. So well on you guys, but hey, the rest of us need to get our act together. And there are many, many, many perceived barriers to provision of adequate obesity treatment. And here's the global ranking of those issues across 68 countries, with lack of political will and decision and action being number 1, lack of healthcare professional training 2, the high cost of treatment 3, poor health literacy, etc., and going down that. And I'm sure you can all relate to this issue. This is not specific to paediatrics, it's specific across the age spectrum. So, while the evidence base for effective treatment is growing, and guess what? We've been hearing about it in Congress and in others I've been to this year, much better access to obesity care is really needed. Let me highlight that there is inequitable and very limited access to obesity care in Australia for young people. In a study that we undertook just not so long ago, there are very few, for example, paediatric multidisciplinary obesity services across Australia. There's none in rural or regional Australia. There are long wait lists between 2 months or up to more than 1 year, and it's a similar situation in many countries. I'm just very aware of the Australian situation. I did my own calculation of the 2% of kids with severe obesity. We're talking about 72,000 of the 5 to 17-year-olds who have severe obesity and need some form of tertiary level service, and current clinics have the capacity in Australia to see less than 5% of them. Wouldn't it be awful if we thought that was the case for acute leukemia or any other significant chronic or significant disease? We really need improved access to multidisciplinary paediatric clinics, and it's exactly the same issue for adults, and I would say it's the same in almost every country in the world. And I'm often mad as hell, and I really don't want to put up with it very much more, but this is part of my psychotherapy, is talking to people such as you. But I've got to do something more. We've got to change things. There's also inequitable and very limited access to obesity care in Australia in other ways. Let's look at primary bariatric surgery procedures, that wonderful bariatric surgery registry. So in 2022, of 16,000 primary bariatric surgery procedures, only 3.2% were in the public sector in this country, where we have the universally highly regarded, next to Jesus, wonderfully seen, Medicare. We have this wonderful universal health coverage system, which with its own faults, and one of the faults is that it doesn't cover bariatric surgery in any significant way. And only 18 procedures, as Sanjeev was said, were reported for people under the age of 18. So we need many more bariatric surgery services in the public sector, including for adolescents. And in Australia and most countries, obesity management medications are not covered by health insurance. We've been hearing about that. In those that do, there can be age limitations or other restrictions, and there was a great paper just published very recently looking at this international coverage and the inequity across many countries. So we really need more equitable access to obesity pharmacotherapy. Further, some groups of people have additional barriers to accessing care in real-life clinical settings, and this is where I work, and the sort of kids that I see. So we see people living with poverty. One of the things I love is the culturally and linguistically diverse part of where we live in Sydney. Come to Western Sydney, one of the most culturally diverse parts of the whole world. Fantastic. But it does have additional challenges in terms of providing great care to people in a way that's culturally relevant. However, in our service in Western Sydney, we have many people with learning disabilities and developmental disorders. We have low literacy in some patients. We see families in crisis and with psychiatric disorders, and we need to actually modify this. And in many regions, services are often poorly resourced or underfunded, may not be publicly funded, and healthcare professionals, as we've said, are poorly trained. So clearly we need healthcare professional training, and that must be improved. Now there's a range of ways in which this could happen. We need to think about a future workforce, medical, nursing, allied health, and the existing health workforce in basic assessment and management of obesity. I'm not talking about the obesity specialist people. I'm talking about primary care, ordinary everyday clinicians, because it's such a common problem. There are limited postgraduate training opportunities, and we need to access all of these people, and we need to reach our clinical colleagues who manage the health problems linked to obesity, including the endocrinologists who aren't here, the sleep physicians, the orthopods, the psychiatrists, the cardiac surgeons, and cardiologists, and so on. So let's think about undergraduate, postgraduate training for many types of clinicians, ideally interprofessional, and often short, modular, online, accessible training. So my question to you, can you develop or adapt existing e-learning training packages? Needs to be culturally and locally relevant, so you can't just drop it in. Now, scope training from the World Obesity Federation is certainly one of those, and we had a great one on Tuesday. Sorry you weren't there if you weren't, but if you were there, you got a great day. There's also formal credentialing of bariatric medicine physicians in US and Canada. But for most people, primary care level skills are appropriate, and for some, specialist clinical training is needed. So what training resources are available in your country, and what training is suitable for different types of clinicians? I'll briefly talk about weight stigma. I just want to say, can role modelling supportive and unbiased behaviours towards people with obesity is really important. What leadership can you do? What language do you do? I just want to keep highlighting we need to be using person-first language, and can we provide a safe and welcoming environment for our people? Now, the other issue, Shirley alluded to this, is that existing health services are generally disjointed and need to be better integrated. And I wanted briefly, the last couple of slides, talk about the chronic disease care model, which is used in many countries for thinking about chronic diseases such as heart disease, diabetes, and so on. This is the Kaiser Triangle, Kaiser Pyramid. So you've got the population-wide prevention, you've got supported self-care, disease management, and a few people need case management. Here's my version for obesity. So we've got primary health prevention, health promotion, really important, completely under resourced, completely not invested in almost every country in the world. Then we've got level 1 care, where most people should be treated. How are we investing in supporting primary care to manage people with overweight and particularly obesity? We need to think about the high-risk patients. Do we have care management? What are our secondary level care services like? Do we have multidisciplinary teams? Can people get to them? And do we have existing tertiary level services? I put bariatric surgery there and linked services. I think that's part of good tertiary level care. Do we have complex patient case management? Well, the answer is all parts of this pyramid are needed, but they're very patchy in most countries. And what is available in your region? What's the relative resourcing of each part? Are they integrated? And what is stopping such services being provided? So, in my final comments, what needs to be provided? Access, access, access. 3 really, really important words. I learnt that from Donna Ryan earlier this year. So to multidisciplinary care, to pharmacotherapy, to bariatric surgery. Access, access, access. In almost all countries, health systems have been very slow to respond to the need for provision of health professional training and coordinated models of care. How can we all show leadership in addressing weight stigma, and what resources and training are most appropriate for health systems in different countries? I want to leave that to reflect on that and to say thank you.